Today on the Morning Medical Update, meet two men, one disease, but two very different diagnoses. Hear their stories and from the doctor who helped them both process the news. Plus, a local doctor is pushing his limits, all to help people with prostate cancer live a much healthier and fuller life. And good morning to you. It is Thursday, October 20th. I'm Jessica Lovell. We are live inside the Dulcie Simons Jr. Family Broadcast Studio. This week, we are dedicating our conversations to the power of a second opinion. The American Cancer Society says 1 in 8 men will develop prostate cancer in their lifetime. And we are going to talk all about this and hear these two really remarkable stories. So make sure you get your questions sent into us through the links on your screen, or you can place them in the chat below. Other than skin cancer, prostate cancer is the most common cancer in American men. It can happen to any man, but there are certain factors that raise your risk, like age, men 50 years or older, family history of prostate cancer, and certain ethnicities or race. The American Cancer Society finds black men are at a greater risk of having prostate cancer. But the good news is you can be screened for it. But imagine getting that screening, then getting a call from your doctor that you have prostate cancer. That is exactly what happened to Moyer Bunting. But a second diagnosis and opinion changed his diagnosis and his future. And he joins us virtually this morning, along with Steve Sutton. Steve was diagnosed with prostate cancer, and it was a second look by his doctor that helped catch it early. We're also joined by their urologist, Dr. William Parker, in studio with me today. Good morning to you.
Good morning.
Steve, Moyer, good morning. Good to see you both.
Good morning.
Hello. Well, Moyer, I want to start with you. You were told you had a rare, aggressive form of prostate cancer. What was that moment like when you heard that news?
Well, it's obviously hard. It's hard to put it into words because everything had just retired the year before, and I felt like I was always on top of my game at that point in time, and it was just a complete shock. I've always been active, and I've been blessed with good health. And we had been doing some traveling. I had just retired the year before. We was doing some traveling and able to go see the grandkids whenever we wanted, and was playing golf a couple times a week. Everything was really going quite well for us. And I can remember when the physician told me the news. I just was in a complete shock. I didn't know how to handle it or how to process that everything. And I can remember asking him how much. How do you deal with your family on these kinds of things? And I remember him saying that he would be glad to talk to them. So I had our 2 daughters and my wife come in and spoke to him, and he confirmed to them what I had heard, a couple of weeks earlier. So, but at that point in time, he was talking about some pretty aggressive treatment and some pretty radical surgeries that would have changed my life dramatically.
This must have been really rough for your family. How did they take that conversation?
Well, I mean, it's hard. Again, it's hard to describe, but we, they were in shock, and and we had, at that point in time, I had been. Started updating some things, and I'm being honest, I was a complete mess. I was running all over the place trying to figure out everything to be done. And I've always been in control of my life, and I've always had in my business life, I was in charge and I was in control, and everything I was able to deal with everything and put it in perspective. But this here was completely out of control, and I talked to our priest, and we had made an appointment with a lawyer, and everything that should be done, because I was given at one point 2 years to live. So things needed to happen pretty quick.
Moyer, I could hear the emotion in your voice, and it's hearing you describe those moments, those days, that time with your family. It hits hard, but there's a there's an ending to your story that I want to get to, and that's what I want to bring in Dr. Parker. And you received news from Dr. Parker that that you were surprised to find out. What was that? That second opinion brought you back to life.
Yes, forever indebted to KU and Dr. Parker. I mean, immediately I called. After a few weeks, I finally was able to process everything and start getting back in control of what was going to be our destiny. And I remember calling the KU, the cancer center. I talked to the nurse navigator, and she was able to expedite. I sent her some medical records that I had obtained, and she was able to expedite my appointment with Dr. I didn't know who at that point in time, but she was able to expedite it, and within just 3 weeks or so, I was able to get in to see Dr. Parker, and he immediately set up some appointments and set to some consultations with some other physicians within the medical center, and
let's bring in Dr. Parker. When you first met Moyer, what were those conversations like? You have an appointment to see a gentleman who has just received the worst news of his life. What did you find out?
Well, I mean, anytime you get a diagnosis that seems fairly significant, like what Moyer had, and in his case, it was a quite odd type of prostate cancer, something that you wouldn't expect.
Rare, and it was rare
and aggressive. A rare and aggressive subtype of prostate cancer that we generally don't see. The first move that I generally make is to verify that's actually what we're dealing with, because rare things are rare. And so you have to question, was this correct or not? And so, a lot of the early conversations were about, what do we do if this is true, but also how do we make sure that this is in fact what we're dealing with? And as the story unfolded, that wasn't what we were dealing with.
Tell me what that conversation was like. I said, I wish I could have been on the phone when you got to have that conversation with Moyer and deliver that news.
I mean, obviously, it's amazing to get to tell somebody they don't have prostate cancer. I unfortunately, by my practice, I have to share a lot of disheartening news at times. It's rare that I get to not only tell somebody they don't have prostate cancer, but that what they were told they had doesn't even exist. And so that was certainly a very special moment.
So is prostate cancer, is it something that's easily misdiagnosed? How could that have happened?
Yeah, so it's not common to misdiagnose prostate cancer. I would say that often what we see is maybe incorrect grading. So prostate cancer is a graded disease, and so we often find that maybe there's over or under calling of the diagnosis itself. Mm-hmm. But this was certainly a first that I had somebody who was diagnosed who didn't have it.
Wow. Okay, I want to bring in Steve Sutton today. Steve, you had a history of biopsies that were all negative until one day they were not. Tell us a little bit about your health history and what you were told.
Sure. I started at KU originally in 2013 with taking some PSA tests. Then with Dr. Thrasher, who was head of the department, who went on to become the president of the American Urological Association. My PSA was probably about 4 to 5 at the time. Over a period from 2013 to 2021, 8 years, I had probably 5 to 6 biopsies. All were negative. The competing issue or the competing fact was my PSA, and the reason I had those is my PSA kept rising. Although all the biopsies were negative, and it rose from 4 to 5 in 2013 to in late 2020 to 27, which is really high. And then on February 24th, 2021, another biopsy that was guided by an MRI that I'd had found one spot of cancer that was diagnosed as low-grade 1 non-aggressive cancer, and then I met with Dr. Parker after that, and this was in that moment, or that point was important because we had to he was telling me what my options were. There was of course the issue about treatment, either surgery or radiation, and or monitoring the status quo. And what I hung on to was the fact that the cancer had been diagnosed from biopsy as low grade 1 non-aggressive cancer, and I went back in my own head to a rubric that I think I may have heard first from Dr. Thrasher, that a lot of men die with prostate cancer but not from it. In other words, that it doesn't grow real fast. And so that was the straw man I kind of held on to, and I elected at that point to monitor the situation. And originally, his scheduling nurse had said, "Okay, well, we normally do that every 6 months for the next PSA test." And I said, "Fine," because that's what I'd been doing. Dr. Parker, however, learned about that after consulting with his nurse, and he said, "No, I want him back in 3 months, not 6 months." I then came, and that was fine with me, and I came back in July, and this is where the importance of that judgment came in, that he, or that test showed that my PSA had increased from last December to July by 10 points to 37, which puts me almost in the double high-risk category. And so then I sat down with him and talked about the options again, surgery. He helped me explore radiation by getting me set up with a radiologist at KU. I evaluated both those things, elected for the surgery, and had that almost exactly a year ago today.
So, Steve, we're talking about second opinions, but also a second look that you really credit, like you said, Dr.
Right.
Parker, with knowing, we call those kind of crucial catch moments where he caught something before it was able to progress. Tell us a little bit about how you knew that maybe he needed to be seen sooner. And then I want to talk a little bit about PSA and what men should know.
Yeah, of course. So, I think prostate cancer often follows in place by some rules. Most prostate cancers follow some set kind of pathway and progression, but every now and then there's a discrepancy or discordance in the bit of information that we have. Mm-hmm. And so in Steve's case, this discrepancy between a very, very high PSA but a seemingly non-aggressive cancer kind of raises my kind of suspicion a little bit that maybe we're missing something, that perhaps we're underestimating the problem that we have. And so, in those situations, trying to rely on the tools that we have to kind of ferret out what's exactly going on led to that earlier PSA test that then kind of drove this process.
So what should men be asking about their PSA? Is PSA you're in the know on because you've had a screening? Is that something you can go to your doctor and say, what's my PSA? Do you have to have a history of it? How do men know this number?
That's a great question. Some of it's driven by the providers they see, right? So certain providers are much more willing to do PSA screening and inform men of what their PSA is and what it means and kind of how to interpret it. But sometimes it's also on the men themselves to understand that this test is out there and they need to have the screening done and to ask so that they're aware of what their number is, and if they haven't had it, to actually get it done.
So how does the type of cancer, if you talk about non-aggressive versus aggressive cancer, how do you know what type of treatment path to go on? If you have non-aggressive, is it a wait and see? Are you kind of scaling back what you do and waiting to see what develops? How does that work?
So it's a continuum. So prostate cancer exists in a big spectrum from disease that's considered very non-aggressive that we often will monitor. So going back to Steve's story, this low-grade cancer, often we do just watch and don't necessarily treat because it's unlikely to harm them. But as the disease becomes more aggressive, those treatment options also have to become more aggressive with it. And we'll often go from kind of being a single modality, maybe surgery or radiation, to having to do multiple different therapies to manage the disease. That's one of the reasons why that kind of straw man of this is a disease you die with and not from is very dangerous, because prostate cancer is the second leading cancer cause of death in men, and it's dangerous to underestimate that.
Well, when we compare it to something like breast cancer, where we always talk about, when you catch this early, the outcome can be so much different. Your treatment options are so much different. Same with prostate cancer.
Absolutely. Early detection is key. I mean, prostate cancer is curable in vast cases when we diagnose it by screening. It's when screening fails or we catch it late that really we start to see that mortality, that risk of death start to increase.
Okay, so I did ask you this when you came in the studio today. I said, Moyer's your patient. I said, but how can he be your patient? He doesn't even have cancer. So tell me a little bit about that. You said, well, I just see him now.
Well, I mean, I follow men who are at risk for prostate cancer and men who also have prostate cancer. And so, you know, certainly Moyer's story is great and it's very exciting. Every time I see him, I think about just what that was. But at the same token, you know, much like that discordance in Steve's case where we had this high PSA and a non-aggressive cancer, the fact that we did walk back, right, from this kind of precipice of a very aggressive disease to now nothing, I don't take that for granted. And so, you know, I still have some suspicion and some level of concern that I don't want us to kind of say, don't worry about anything, you're going to be fine.
Of course, because he also had the history with the bladder cancer. So that would make him at risk, or are all men at risk?
I mean, all men are at risk.
Yeah.
This is a disease that if you live long enough, we can find. And so it's just a matter of finding the disease that's going to potentially hurt you versus the ones that will not.
So, Moyer, I have to say, as we've been talking, your power of a second opinion story is particularly powerful, yet very rare, as you've mentioned. I mean, you don't want people to think that you're going to get a diagnosis and that you're going to be able to deliver that good news every time. So I want to know how this diagnosis that changed your life for the better, but how does it change your approach to life now, Moyer?
Well, and I would like to go back and add, too, that in 2012, I was diagnosed with some bladder cancer, and I had been getting some follow-up with that. And so, again, at that point in time, you know, the diagnosis was such a shock, and had taken it for granted that was going to be part of it. But I mean, it's cliche to say that, you know, everybody has to be an advocate for themselves. And so the importance of getting a second opinion, taking charge of your health care, and, you know, cannot be underestimated.
I want to check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, for a brief moment as we get a quick look at our COVID count and some headlines this morning. Good morning to you.
Yeah, hi.
Hi.
Hi. Today, 17 active infections in the hospital, 3 in the ICU, 1 on the ventilator, still 23 in that recovery period. But overall, I think, you know, we've been somewhat happy or optimistic about our lower numbers than they have been, especially as we do anticipate some sort of surge this coming winter and into this fall. Don't know what that will look like, but hopefully we can keep these numbers as low as possible.
So, Dr. Hawkinson, I want to ask you about possible concerns. We're hearing about the increase in RSV cases among school-aged children, filling up emergency rooms, taking up hospital beds. This is expected to be one of the most severe flu seasons we've seen in a while. And then we've been talking about the variants that you've been mentioning over the last week or so. What is your take on this, and what is your concern level?
Yeah, I mean, we know, so COVID-19 cases are going down, hospitalizations are going down. We know flu activity for the most part in the United States is low, but it is increasing. It continues to be incumbent upon everybody to take their own health into their hands. And that is by being vaccinated, being up to date with vaccination. That is the first thing, is that prevention. You know, certainly we are ready from a capacity standpoint, but as we talk about surges, it's not only the people that are coming in ill, but it's also making sure that we have the healthcare workers to be able to treat you when you do come in ill. So it is a concern. I know that the health system, we are preparing for it. But again, it starts with every individual and getting them up to date and vaccinated.
Have to ask you about monkeypox cases. Good news, they are way down, but some infectious disease experts are talking about the idea that the U.S. could just eliminate the virus. Is this something you agree with?
You know, I think that will be hard to do. I think there still is not enough information about that. We know that the virus has been circulating in some sort of epidemic level for quite some time in Africa and in certain countries. We could have stopped it then. Unfortunately, we know that there are probably animal reservoirs and hosts that are the natural host. Certainly, we would like to eliminate the human cases, and I think that is very possible. But it starts with what we're doing right now, continuing to watch the trends, but also identifying if other groups of people or if other individuals need vaccination as well. So I think it's a little bit too early. Certainly we would like that, eliminating the virus from human infection here in the United States, and then also work globally to do that too, because I think that can be done, and that just takes a larger world view and understanding that we have the resources to do it. We just need to put forth the effort.
All right, Dr. Hawkinson, thank you. Let's check and see if there are reporters on the line today. All right, let's get to some great community questions because we are already getting them in. Jenny has a question for Steve. Steve, did you have a family history of prostate cancer? What did you know?
No, I did not at all. So I didn't meet that standard, but still have it, or still have it. I mean.
So what were the signs? And were you a guy who was kind of up on your health? We talk a lot about, I was just asking Dr. Parker, are men getting better at taking their health into their hands and getting to the doctors and getting checked out? Were you a regular screener and doctor visitor?
Well, yeah, I was up on my health, and I started, with one screening originally in 2013 because my physician had suggested that it had increased a little bit. And so I ended up with KU and stayed there and had great experiences all the time. Every biopsy came back negative until 2021, but the PSA kept rising. And so I paid attention to that, and I knew that, every time I had this dilemma that a negative biopsy, but still a rising PSA, but I listened to my physician and followed the advice to continue with both the PSA testing, which revealed an increasing PSA, and then further biopsies that ultimately resulted in unfortunately a positive diagnosis, but then got further great advice from Dr. Parker that led to a very positive result, a great surgical result. And I didn't say earlier, but I've now had 4 PSA tests that were all negative over the last year, which is as good as your result post-surgery can be.
So is it no evidence of disease, Dr. Parker, for Steve? No evidence of cancer?
Correct.
We never say cancer-free, right? He'll continue to be monitored.
Correct.
Steve mentioned no family history that he knew of. How much does family history play a part?
So family history increases the risk. So we know that if you have a single first-degree family member, so father, brother, your risk is going to be about 2.5 times increased over the average population risk. But you have to remember the average population risk is 1 in 7 men. So while family history plays a role in identifying men who are at a higher risk, not having a family history doesn't mean that you don't have a risk of having prostate cancer.
Juan wants to know, what are the main causes of prostate cancer, and is it preventable?
So we don't believe that prostate cancer is preventable. We also don't really fully understand entirely what causes prostate cancer other than being a man and having a prostate. We believe that there are some genetics that factor into it, but we don't, and we haven't completely unraveled the question of a cause. It certainly isn't felt to be environmental, meaning that there's not something that we take in or ingest that then causes us to be at risk for prostate cancer, which means that similarly there's nothing you can avoid to prevent that from happening.
But you can do what both of our guests did, which is take the best darn care of yourself you can, so that if that were to happen or develop, that you've stacked the odds in your favor. Dan had a question, and you mentioned it, asked if it was true if a man lives long enough, he will develop prostate cancer, but not necessarily die from it, correct?
Correct. So there's this difference between what we consider as age-associated prostate cancer, the ones where you start seeing them accumulate in men in their 70s and 80s, which are unlikely to actually cause any harm ever, versus the ones that are diagnosed earlier in life, in your 40s, 50s, 60s, that are actually destined to cause harm if they're not treated.
Okay, I have to ask you something, and it just dawned on me, because the question from Terry was, what's the screening process like for prostate cancer? Is that I'm not a man, is it a prostate exam? Is it testing for the PSA? Is it a blood test, or is it all of the above?
It can be a combination of all the above. Certainly a prostate exam, so a digital rectal exam, is important in the screening process, at least initially and periodically. It used to be that digital rectal exams were performed yearly. I don't necessarily think that's necessarily required as long as the exam is normal initially. But PSA testing is the backbone. So a blood test, a simple blood test, is the key to figuring out whether or not you're at risk for prostate cancer or not.
So Leslie wants to know if she needs her husband to get a second opinion, what are your recommendations on where to research to look for one besides coming to you, but what questions to ask. What are things that you're hearing one place should you be looking to hear from somewhere else, and how do you compare the two?
Yeah, I think that's a really good question. Certainly beyond, saying you should come here and visit with us, I think any academic center is important. So getting information from academic websites, academic centers is important. There's a place called the National Comprehensive Cancer Network. It's a website. It's a repository of guidelines. It's available to the public. It's something that you could easily look at. And the value there, the importance there is making sure that what you're being offered as treatment actually aligns with what should be being offered. So I would say the biggest thing that I see in second opinions that is kind of neglected is guideline concordant care, is following what exactly should we be offering, or what should that patient have been offered for their treatment.
I want to get to final thoughts from our guests. Such an important conversation. Moyer, I want to start with you. What are just some final thoughts and your message for our listeners today?
Well, again, I think that just the biggest thing here is it's okay to ask questions. I mean, I worked in healthcare pretty much my entire life, and kind of was fortunate enough to know my way around the healthcare system. But I think most physicians are happy if you get a second opinion. And like I said, I'll be forever indebted to Dr. Parker and KU for everything that they've done for me and continue to do for me. And I guess the biggest takeaway for me is just take charge of your health care and
Thank you, Moyer. I know I talked to you on the phone. You said you weren't a TV guy, but you said you are indebted to this man to my right, and that you wanted to be here for Dr. Parker. So it must be nice to see your patients doing so well, right?
Thank you.
Let's talk with Steve. Steve, what is your final thoughts and message for our viewers today? What should we know?
Well, it's a lot of it is the same. I'm extremely grateful to Dr. Parker for his judgment and his surgical skill. I've had a great result post-surgery, and I've also really appreciated what we discussed earlier, his opinion to come back sooner than later with regard to the PSA test, which may have prevented the spread of prostate cancer from it to somewhere else in my body. And the result's been terrific. I've had great service both at his department over the years and also at the hospital. The day of the surgery, it was just fantastic, and I can't thank enough both KU and Dr. Parker for great treatment.
Well said. And thank you both for just being here to share your story and being good advocates for yourself and for other men out there, that it's okay to check yourself and to ask those questions. Dr. Parker, final thoughts from you today.
Well, certainly thank you both for coming and sharing your stories. I do appreciate it. I'm grateful for you all to come to see me in the first place as much as y'all expressed. So I think just seconding what Moyer said, I would say be an advocate for your health care. Ask questions. I see folks as a second opinion. I also have people leave me and go see a second opinion. I think that's great. I think getting information is the key. So don't be afraid to ask questions and find the information that you need.
Quick question. Angela wants to know, will genetic testing show family history when you do a genetic test?
It can.
Okay.
So there are indications for genetic testing in prostate cancer, and it can influence that risk of screening.
All right. Thank you so much for
You're
being here
welcome.
with us today. We appreciate it. Great
Thank
information. Dr. Hawkinson, final thoughts from you.
Again, as we saw last week and right now as well, just good stories about prevention and screening and doing those things that are important to help you continue to live a healthy life, just as you mentioned, Jessica. Certainly that begins with vaccines. Be up to date with your vaccines, especially be up to date with the COVID boosters now and influenza vaccine. We know that and expect cases to be surging, and we know that there are other viral variants that are circulating in this variant soup. Still not one has really taken over and been dominant, but we know that the vaccines continue to work, so just continue take that upon yourself and talk with your loved ones and your family members to do those preventive measures.
Dr. Hawkinson, thank you so much. Well, this next story is a story of true grit. An Ironman race is not for the faint of heart. We certainly know that. But Zachary Collins, he competed in the Ironman World Championship in Hawaii. He is one of our fantastic doctors here. And with the help of his colleagues here at the health system, he raised $50,000 for Team Zero.
So Team Zero is basically an organization in Washington, D.C., and they're focused on awareness for prostate cancer. So they fund research and they help just organize a national campaign on awareness. In my fundraising campaign, because I had to raise $50,000 for prostate cancer awareness, I met a bunch of great people. I met this guy named Steve Henson, who's the head of the Prostate Network here in town. And he's done a great job on the local scale in terms of raising awareness. And some of his deputies were a guy named Caesar Blevins, and then Buck Summercamp, who was their sound guy, because we did a podcast together. Unfortunately, they both passed away relatively recently, and so I raced in honor of them. Knowing that I had people, up above looking down, I couldn't disappoint them. I couldn't stop at any point. Failure was not an option here.
Dr. Collins completed a 2.4-mile swim, a 112-mile bike ride, and a 26.2-mile run in 13 hours and 45 minutes. I'm exhausted just reading that. So congratulations, Dr. Collins, way to go. Well, All Things Heart is coming up at 10 a.m. this morning, and Alexis Del Cid joins us now with a preview. Alexis, you're going to be talking this morning about Down syndrome in the heart. Tell us more.
Jess, we have an amazing woman to introduce you to. Her name is Lucy. She's a patient here at the health system. She's in the Adults with Down Syndrome clinic. She also happens to be an employee here, and she's an incredible dancer. But when Lucy was born 25 years ago, her mom was alarmed when the doctors told her Lucy would need heart surgery.
I was really scared, but I had a very strong husband who said God didn't give us anything we couldn't handle.
I had holes in my heart, like 3 of them. I was 4 months when I had my open heart surgery.
And it turns out Lucy has the same heart issue that doctors say is incredibly common in patients with Down syndrome. So we're going to talk about that and the surgery to correct Lucy's heart. We're also going to talk with the nurse practitioner who runs the Adults with Down Syndrome clinic here at the health system. And of course, we're going to get to know Lucy better because Lucy really is living her best life. She's the kind of person that just makes you happy being in the same room. And I'm telling you, she can dance. So that's all.
She can dance.
Oh, she's so good.
Alexis, she can dance and she makes really good ice cream. I hope you tell everyone about that too.
We do, yes.
Okay.
There is an ice cream flavor named after her.
I know,
so that's
right?
all, yep.
My kind of girl. My kind of girl. I love it.
She's great. So that's at 10 a.m. So bring your questions.
All right, we will. Alexis, thank you so much. We're looking forward to that story and meeting Lucy. And thank you so much for being with us today. You can catch our updates anytime by logging onto Facebook, YouTube, and Twitter. We're going to see you back here tomorrow at 8 as we wrap up our series, The Power of a Second Opinion. Coming up tomorrow on the Morning Medical Update. She was told her blood cancer was so rare and so aggressive, her treatment options were very limited. I'm Jessica Lovell. That was the case for Marjorie Harper until she got a second opinion at the University of Kansas Cancer Center, where doctors took her from hospice to hope. Her story Friday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.